Welcome, everybody. This is the webinar by the Australian National Research Organisation for Women's Safety, ANROWS. I'm Professor Penelope Weller from RMIT University. I'd like to begin by an acknowledgement to country. I'd acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional custodians of the unceded land on which we meet today. I also would like to acknowledge the traditional custodians of the lands of all of you who are watching this webinar or joining from other places. I pay my respects to elders past, present and emerging. I would also like to acknowledge today the impact of COVID-19. This is affecting everybody, particularly consumers of mental health services, women experience domestic and family violence, and practitioners in mental health and frontline services. Our webinar today is entitled Safe for Women, Preventing Gender-Based Violence in Mental Health Inpatient Units. Our panel today is Dr. Juliet Watson from RMIT University, Professor J. Ashri Kulkarni, a psychiatrist from ALFRED and MONASH Hospital, Brenda Eden, consumer advocate and academic, and Charlotte Jones from the Mental Health Legal Centre. We are going to give everyone an opportunity of our panel to speak. Then we will have some panel discussions, and there'll be an opportunity at the end of the seminar for people to submit questions for the panel. So please prepare your questions as we go along. So to begin the seminar, can I turn first to Juliet. Juliet, could you please tell us about the research preventing gender-based violence in mental health inpatient units?
Yeah, thanks. So I was the principal chief investigator on the project. A bit of my background, I'm a senior lecturer and researcher in the Social and Global Studies Centre at RMIT University, and I'm a sociologist and social worker with research, teaching and practice experience in gender-based violence. So we set up this project funded through ANROWS, and we had two clear aims that we were looking at with this research. The first was, what are the experiences of gender-based violence for women staying in mental health inpatient units? And secondly, how can these experiences inform and improve policy and service delivery? So for this project, we took gender-based violence to mean any form of violence perpetrated by men against anyone who self-identifies as a woman. And this can include different kinds of violence, such as physical, sexual, psychological, economic, and spiritual violence. So in setting up the project, we partnered with the Mental Health Legal Centre, Northwestern Mental Health here in Victoria, Victoria Legal Aid and Charles Sturt University. It had a few aspects. There were a few aspects to the research. We began by just reviewing the existing Australian and international literature to see what had already been conducted and learnt from other jurisdictions. We also conducted an extensive policy review of the relevant state and territory health departments and mental health services in Australia. We were guided by a project advisory group that included consumers, mental health advocates, service providers and academics. And we also consulted with the Victoria Legal Aid Speaking from Experience Mental Health Consumer Advisory Group. Once we'd done our reviews, we'd set up our advisory group. We then proceeded to interview women with experiences of gender-based violence while staying in mental health inpatient units. The women we spoke to had experienced some form of gender-based violence in the previous 5 years. We spoke to 11 women. We'd hoped to speak to more than 11 women, but I mean, these projects can be difficult to run for all sorts of reasons. So we were very grateful for the 11 women who did choose to speak to us and gave us very, very rich information about their experiences. From these interviews, we then developed a series of case studies. So we de-identified specific information about the women, put together some case studies that we then presented at 4 workshops with service providers. We had a total of 42 service providers attend these workshops. And we asked the participants in the workshops to examine these case studies and I guess reflect on what they thought might have happened in these situations, how these experiences of violence came about. And I guess one thing that was clear from the workshops is that the participants were not surprised by the experiences we were describing to them. And we asked them to think about how they would respond if these situations emerged in their workplaces. We used the feedback from these workshops and the information we received from the women that we interviewed to develop a set of guidelines, which I'm going to talk to a bit later. But we developed a series of guidelines that we wanted to see implemented in all mental health inpatient units across Australia. After we developed the guidelines, we then sought feedback again from consumers to get their impressions of this. We, of course, gave it to our advisory group, and we held another 2 workshops with a further 21 service providers to get their feedback on what we'd put together. I'm just going to speak briefly about 3 key findings from the research that we found. And I guess the first and most important aspect is mental health inpatient units are not currently able to keep women safe from gender-based violence. It's going on. Women are exposed to a range of behaviours that constitute gender-based violence, harassment, physical violence, sexual assault. Most of the women we spoke to talked about violence perpetrated by male consumers who were in the units, but there were also examples of staff being involved too. Something that also came up with the women is that there are practices that go on in inpatient mental health units that can be experienced as gender-based violence. So things like practices of restraint and seclusion can be experienced as a form of gender-based violence. The second main finding is that the physical space or the built environment is a crucial aspect in being able to keep women safe. Different wards are designed in different ways, but it seems wherever there is shared space, women are not safe from gender-based violence. And even where wards are designed with, say, separate corridors for men and women, there's a lot of pressure on staff to be using these beds if they're available. So putting men in the women's area, women in the men's area, which, you know, defeats the purpose of having separate areas. So staff are under a lot of pressure to do this, but unfortunately it means that women are unsafe. And the third finding well, we have more than 3 findings, but the third main finding that we came to was that women who've experienced gender-based violence are getting mixed responses from the staff and from service providers. And certainly some of the women spoke of some positive responses, but in the main, they reported responses that they weren't satisfied with. Now, I mean, of course, some of this is based on the women that we spoke to. The women who talk to us perhaps are more likely to speak to those negative experiences. But, you know, if those negative experiences exist, we need to listen to them, of course. So the women spoke to there being a lack of trauma-informed responses, that they weren't taken seriously, that if they'd experienced harassment, that something wasn't put in place quickly, which meant that there was a quick escalation of violence happening against them. And this left women feeling like they had to take responsibility for their own safety. They couldn't rely on a staff at the unit to protect them. And this could then have the effect of women leaving the unit early before they were perhaps ready to, and avoiding going into mental health inpatient units in the future because they felt unsafe there. So I'll finish up there and hand over to the next speaker. Thank you.
Thanks very much, Juliet. We'll have the opportunity to discuss and analyse your key recommendations later in the webinar.
Sure.
So that will be great. Let's turn to our next three presenters, and each of these are going to talk about, from their own experience, either practice and consumer advocacy around preventing gender-based violence in inpatient mental health units. So if I could first turn to Charlotte Jones. Charlotte Jones leads the Mental Health Legal Centre based in Victoria. Charlotte, as a practitioner in the mental health legal sector, what issues do you see with the client's experience? How does the system respond to gender-based violence in mental health inpatient units?
There's a number of conflicting factors often for the women trying to report incidents which occur on wards. One is that the police won't take the calls from the wards themselves. Often they get redirected back into the staff. So whilst a woman may be trying to report a crime, she's actually not able to do so. The other thing that happens is that if the women report the matter to the treating team, this can then be seen as part of the ongoing illness and used as a method to maintain them on the ward. And the other thing that we've experienced is that women are told that they have imagined all of the events that they have reported, and that's how the complaint is then dealt with. So those three responses leave the women often feeling more vulnerable, more afraid, and more scared than they were when they started.
Yes, thank you. We'll have an opportunity to talk some about barriers to Charlotte when we get to the end of the seminar. So thank you very much. Now may I turn and introduce Professor Jayashri Kulkarni from the MONASH ALFRED Psychiatry Research Centre. So Jayashri, from your point of view, can you tell us about your experience in advocating and influencing policy and practice changes to prevent gender-based violence in mental health inpatient units?
Yes, thank you very much, and I'm delighted to be here, and I'm very pleased that ANROWS has taken up this particular issue. My role is that I'm a consultant psychiatrist. I've been a treating psychiatrist for a long time in the public sector, so I've been on the treating end, and then I became the Director of Psychiatry at Dandenong Area Mental Health Service for 9 years, and then Professor of Psychiatry at the ALFRED Hospital, where I'm also a consultant. So in all of this time, I have been an active clinician as well as a researcher, as well as an advocate and academic, and I still have clinical practice. In particular, my expertise is in women's mental health, and that's what I've spent a long time working in and still have a lot to do. So the history of this situation really, and again, I'm sorry to bore people, but it is important to understand why we're in the predicament that we're in. The history of the situation goes back to the 60s, the 1960s, when there was an attempt in the big mental health asylums or institutions as they were in Victoria back then to try to, in inverted commas, normalise behaviour for people who were managed as inpatients back then. So that meant that people thought it was a good idea to have male patients and female patients co-mingling. Prior to that, there had been separate women's wards and separate men's wards. But because people were staying in hospital for a very long time, and I'm talking months to years, it was thought that this was an unreal environment to have such separation of the genders. And so the genders were mixed, and that was to simulate normal life. Now, over time, of course, things changed, and in the 1990s we had deinstitutionalisation, where the big hospitals, the Royal Park, Larundel and so on in Victoria and their equivalents across the country, were deinstitutionalised, and people were moved to smaller wards in the public hospitals for inpatient treatment of mental ill health. This then meant that community treatment was the mainstay of treatment. And so anyone who could be treated out of hospital was treated out of hospital, and really the sickest and the most unwell groups were managed in hospital, but still managed in that commingled form of the genders that had been inherited from the big institutions. So you can see that what's happened is over time, the acuity or the severity of illness has rapidly increased in the inpatient units. So you take out the people who could be managed in the community, and you're really left with the very severely unwell. Add to that the more recent issues of ice and other amphetamine drugs, which of course disinhibits behaviour. So you've now got the sickest of the sick, as well as disinhibition due to drugs, as in street drugs. And this is our current environment in the inpatient units. So over time, I have been increasingly horrified, and still am horrified, about any and every assault that happens for our people with lived illness who are managed in our inpatient units. In particular, women are experiencing and have experienced considerable assaults, ranging from verbal through to physical to sexual assaults. We've conducted research that's been published, and we've published on samples, quite large samples, looking at incidents, interviewing the individual women and interviewing their case providers, their healthcare workers, and we've published all of that. Look, I'd say it was about 10 years ago. I don't have the paper in front of me, but that has been one big study that we did back then. We've done literature reviews and so on. So, you know, the research is there, and again, I'm delighted with colleagues who have done further research, but we're all going to be saying the same thing, and I'm sorry, but it is a quantification of the bleeding obvious, that this is a situation where you've got very, very unwell individuals, disinhibited, commingled. You're going to have problems, and the weaker members in terms of physical strength are the ones that are suffering the most. So with all of that in mind, I have been lobbying politicians since the early 2000s, when it became apparent that this was an escalating problem. And it's a very, I think, a very fraught situation that when you speak to the person in the street, and you say, this is what's going on in our public hospital psychiatry wards, they immediately go, well, that's ridiculous. That cannot be allowed to happen, and it doesn't happen in other areas of medicine and surgery in our hospitals. When you speak to politicians, they all have different colours, different parties. They all say, oh, that's not good. We should do something about it. And this is a joint issue. It's not one particular party or the other politician's issue. It's a joint issue. And then, of course, you speak to the mental health workforce, and they will tell you that, well, you get a whole range of responses. You get a range of, it's always been practiced this way, through to, well, there's nothing we can do about it, we're doing our best, we're under-resourced, the capital works are terrible, you know, the buildings are old, and so on. But everybody shakes their head and everybody says this is terrible and it should not happen. And lastly, before I finish up, just to give you another feel for the issue, we were delighted when the Mental Health Complaints Commissioner, the MHCC, which reports to the Public Advocate, has an independent reporting to Parliament role, took up the issue of sexual safety, and they produced with us, we were commissioned to do work. We did more research. We also did interviews around Victoria, and a particularly good piece of work was published by the MHCC called The Right to be Safe, Ensuring Sexual Safety in Acute Mental Health Inpatient Units. So this was launched in March of last year, and it has excellent recommendations of how to go about improving safety in our inpatient units. And to date, very few of them have been taken up, but we are, of course, waiting for the Royal Commission in Mental Health in Victoria to actually come down with some findings about that. But I still think that as a total community, we have disparate responses. I think there is a little bit of compassion fatigue or something going on in the inpatient units. I think we have terrible issues for the women who have lived experience and are inpatients, and we should be advocating even stronger for them. And then we have the issues of everybody crying poor, that they don't have the money to be able to build units that have single rooms, that have separate areas, that have separate en-suites, which are the critical areas where such incidents occur. We also have an insurance system that picks up the tab if, for example, a woman does put in a legal complaint through the courts. It doesn't then impact on the budgets in a way that would then enhance action. We have everybody agreed in principle, so why are we not seeing the actions?
Okay, thank you. Perhaps we can come back to that question at the end. Now, can I turn to Brinda? Brinda, you're a consumer advocate and academic from the University of Melbourne. And so my question for you is, from the perspective of consumer advocate, what issues do you see around gender-based violence in mental health inpatient units, and how do you think this violence could be prevented?
Thanks, Penny. I've worked in consumer advocacy roles for over 20 years now, and I want to thank Charlotte for the points that she made. They were all points that I also want to underline about things like police responses and not being believed, and I think that these are really important things that we need to address. I guess I want to start by sharing that I actually have changed my view on this over my work life. And when I first started working as a consumer advocate, I wasn't that supportive of separate spaces. And the reason that I wasn't supportive of separate spaces is because I believe the underlying problem was practice, that the very practice of consumers, the practice of nurses and psychiatrists not believing consumers, believing instead that this was all a figment of their imagination, or that they brought it on themselves by their disinhibition or some other factor, and that we needed to address these things in order to make these spaces safe. Many other health wards in all other sorts of health services are mixed gender. So why was it different in mental health? So I didn't start out in my life, in my consumer work life, advocating for separate spaces. But I've come a complete turnaround in that time. I've seen wards that consumers were part of designing that are separate bedrooms, that are patient-controlled bedrooms. So they get to say who comes in and out of the units, that have that are en-suited, and there is still gender-based violence in those units. And this is significantly because of the culture of the ward and the culture of staff staying in staff stations and not actually being out. And this has all led me to believe that we can't actually change that under current conditions, and we need women's only spaces. When I started advocating for a women's only ward at a service I was working at, they were in favour of it, but only if men could also staff the unit. And I firmly believe if you're going to have a women's only space, it needs to be a women's only space. And that includes staff. It includes cleaning staff, nursing staff, domestic staff, psychiatrists. Everybody in that space should be female. I think that's the only way to make it really safe. I do think that we don't focus enough on consumers who accuse staff, and the Right to Be Safe report, as good as it was, actually did not address that issue, said that there were other processes that are in place to address that, and those processes don't actually work, and I know that from experience. From talking to consumers who've had those experiences. So I think that that's something that we need to address, and not focus just on the consumer violence. We also need to think about the other violent practices, such as Juliet mentioning seclusion and restraint, and how those sorts of violent experiences are experienced differently by women, particularly women who have a history of other types of gender-based violence in the community. The final point that I really sort of wanted to make here was about the value of peer support workers in these spaces. And I think that we should be thinking more innovatively around how we can use peer support workers in inpatient units, particularly if we go to women's only spaces. I'd really like to see much smaller units managed, staffed by peers, and not these big 20, 25 bed units in hospitals that focus on illness and deficit rather than focusing on what the consumers are actually saying they need.
Okay, great. Thank you, Vrinda. And thank you to everyone for your contributions. It's given us a sense of some of the reasons that we're in the place that we are now, but also some opportunities for further exploration. And each of you have made some suggestions. So at this point, I think I'll return back to Juliet and have a think about the guidelines and recommendations that the project team have developed in response to their research. So Juliet, would you be able to explain to us your key recommendations?
Yeah, sure. So I guess there have been some documents referred to already, and we looked at what was out there, and we were interested in putting together some recommendations in the form of guidelines that took into account what was already going on in places, but also what might be missing from key policy areas. And we established some key principles that underpinned these guidelines, and they might seem obvious, but we thought it was important to make these explicit. And these were the principles of safety, recovery, gender sensitivity, dignity, autonomy, and choice. And our belief that anyone who is experiencing a stay in an inpatient unit has the right to these principles. So these principles are embedded in our guidelines. Now, when you look at our document, you'll see that the guidelines go on for pages. So I've just pulled out a few key aspects from each overarching guideline, but there are many more to look at. And firstly, we looked at the importance of promotion. By that we mean we actually need to be able to sincerely promote mental health inpatient units as safe places for women. So there needs to be work that already goes into that so that women feel safe on entering. And I mean, this has come up already with the idea of having segregated wards, that when women enter these wards, these environments, they feel safe. Our second guideline heading, I guess, is prevention, and that is ensuring that gender-based violence doesn't occur in inpatient mental health units. So rather than having to respond to gender-based violence, we're saying, well, if it's prevented in the first place, which is, I think, what we all want to do, that gets rid of a lot of these problems. And again, you're looking at gender-specific wards here as being a key aspect of this. Now, if any violence does occur, this comes to our third area, which is early intervention. So if an incident of gender-based violence occurs, we want to see staff trained thoroughly in trauma-informed responses. When we spoke with the workshops, there were mixed responses to what trauma-informed work actually is. We need to have consistency here. We need an acknowledgement by people working on the wards that women, often come in having already experienced gender-based violence and being attentive to what that means, being on a ward. Our fourth area is incident response. So this should be quick and appropriate, and most importantly, coming from a position of belief. It's not for the service providers to be playing detective on the wards. They're not the police. They should be supportive. They should believe what the women are telling them and respond appropriately. The fifth area is around incident reporting and recording. And we're saying, well, women actually need to have control over this process. If they want something recorded, it should be recorded. So incidents need to be documented. But it is also being led by the woman as to how she wants to proceed. So I know the issue of mandatory reporting came up in the workshops, and most of the people we spoke to thought this was a good thing. But just something to consider is that if a woman was assaulted outside of an inpatient unit, it would actually be up to her whether she wanted to report this or not. So should we be treating women differently on the wards from how women are treated in the general community? Our sixth area was continuing care. So this is providing ongoing support after an incident of gender-based violence. And I think this speaks a lot to what Verinda was talking about before, that women having access to peer support in these situations and to specialist counselling as well. But the women we spoke to as part of our research very much talked about how the advantages of having peer support, the advantages of that for their experience of being on the wards. And of course, women should not be put in any space with a perpetrator of violence at all. If they've been assaulted by someone, they shouldn't be then put back on the ward where the perpetrator is. We then have the area of data collection. We need transparent, reliable data to be collected on what's actually going on in the wards. If we're not being clear about what's happening, we're hiding the issue and we're minimising it. And finally, I'll just speak briefly about oversight and monitoring. So we need this to be going on at the unit level, the service level, the districts, the state and territory level, and national levels. And, if we're actually looking at changing policy or implementing changes, we need timelines for compliance and reporting to be developed. Thank you.
Great. Thanks, Juliet. So it's a lovely structured way of thinking about the response. Can I open now to the whole panel? I would like you to comment on how you would see these recommendations and guidelines being implemented, and with a particular sense of what would be our next steps, ensuring the safety of women and the reduction of gender-based or the elimination of gender-based violence in mental health inpatient units. Perhaps we can start with Verinda.
Thanks, Penny. The recommendations all do sound really good. Don't quite go far enough, I think, for myself, but are a good place to start. I do think we should be focusing any work that we're currently doing on moving a lot of mental health care out of health services. I think this is one of the significant problems we have, is that when women are in a mental health service, when they're there because of a trauma experience that is manifesting and being diagnosed as a mental illness, this is a significant problem in them trying to address ongoing issues of gender safety. So I would like to be saying we should be concentrating more on peer support services and doing more in smaller community-based services, having respite, peer-run respite services, peer-run alternatives to ED, peer-run alternatives to crisis services, and that they should be small and in the community. One of our big problems, I think, that I've seen in Victoria is actually the removal of the small community-based services into big amalgamated corporations. And I think that we could see a significant change if we moved back to smaller services.
Okay, great. Thank you. And Jayeshri, would you like to comment?
Yes, I mean, I think you can hear from my voice that I've been in this situation of advocating and wanting change for a very long time. So I'm quite frustrated at the lack of change and the lack of movement on what I think is an obvious area that can be improved. There's a lot of things in mental health that we don't have answers for or solutions, but this is not one of those. So in the recommendations from the Right to Be Safe, we argued backwards and forwards with it, and I was one of those who's, again, with Brenda, said, why don't we just have segregated wards? It would actually be a concrete solution even at this stage, and that was seen as too difficult, too radical, and so on. So because, and I'll tell you the arguments, people put forward the arguments that they said, then it becomes like a jail, it becomes custodial, it becomes too difficult, what do you do with transgender and so on. And there are answers to all of that. No, it's not custodial because, again, there's a duty of care, there's a difference in how people are managed, etc., etc. There are also the transgender issue. I don't think we should buy that red herring because the solution is to ask the individual how do they identify and then go with that. So, I'm just frustrated that the issue is there, the research is there, the public opinion if the public become more aware of this issue, the public opinion, and Joe Blow and Josephine Blow in the street are shaking their head going, I don't want my aunt, daughter, sister, wife to be subjected to this. So, we have solutions, and yet we're not able to implement them. And that's one of the things that I think is a difficulty. The time, I think, is done for education, and we need to do something concrete first and then get in with all the other bits and pieces. We've tried and tried with education programs, tailoring programs to meet women's needs. I've been on several committees. This is a capital works issue. And if we can get the capital works improved, it will immediately make the mental health system look different. I totally agree with Brenda that smaller units are the way to go. But again, you're talking capital works and money, and that's where we keep coming up against a big roadblock.
Right. Okay. Thank you. Thank you very much. Yes, it is often becomes a roadblock. Juliet, can I then turn to you to just finish off or perhaps respond to those comments?
Oh, look, I completely agree with what Jayashree and Brenda have just said. And I know I went through quite a long list of recommendations there, but the clearest message that came through from our research was the need to have separate wards. And, I agree, if we can get this in place, then so much can change from there, and then we can look at working on other areas. But absolutely, that was the key message that came through from this research.
Okay, the need for separate wards.
Yeah.
Thank you very much. From my point of view, it makes me think that it would be possible to achieve this through some shifting of the way we utilise our current resources, not just to build new capital works necessarily. Jayashree, may I ask you, is the area health system perhaps one of the barriers to us doing that?
Absolutely it is. And in our reviews, we went around Victoria where there have been incidents, and teams were set up of very experienced clinicians. And what we noticed is in many of the mental health services, even as they exist, there are often two wards, right? They've got weird geographical boundaries, but there are two wards. And we often ask the people, why don't you make one the male ward and one the female ward? And then we got all there, what do you do with the transgender group? What do you do, et cetera, et cetera? So there's a sense of inertia, and that's the thing that, people all shook their heads and said this is terrible, and clinicians felt dreadful when there were incidences. Not to mention, of course, the disasters for the individual experiencing it and her family. But, nobody says this is not a problem. But when it comes to the solution, we get so many obstructions that I just think we need to really dynamite out the solution and then, with a Brave New World, sort of approach a whole bunch of other issues. And yes, there are two wards often in many services. One could be turned to this and one could be turned to that. But, let's move on.
Okay. Thank you very much for that comment, and thank you all for the comments on that session. What I'd like to do now is open up to questions from those who've been listening to our webinar. And I have one here, if I may start. It's from Brenda. It's for Brenda and Jayashree. And the question is, why are mental health inpatient services so trauma illiterate? For instance, the only trauma and dissociation unit in Australia is a private one in Brisbane. Do you think lack of trauma-informed practice and trauma healing modalities in many hospitals contribute to violence against women in these units? So that's for Vrinda and then Jayashri.
This is it's a great question. It's a really great question. I actually think that you, in a service, in a hospital ward that works under the Mental Health Act, it cannot be trauma-informed. And I've been brought to this understanding through some really great consumer advocates such as Indigo Daya and Kath Roper, that when you are doing traumatic things to people in mental health services, such as seclusion, restraint, forced medication, detaining against their will, you can't do good trauma-informed care. It's almost an oxymoron to put those two things together. So I think that we need a much bigger, much stronger, much more radical change to the way that we care for people in acute distress.
Okay, thank you. Jayashri?
Yeah, I mean, I echo a lot of what Brinda's just said, but I also think that part of the issue here is a fragmentation of the system. And so people in the mental health system, clinicians, are really only looking at bits of what's happened to the individual. So, for example, the person might be seen in the ED, the emergency department, in a crisis, and then they're transferred quickly to an inpatient unit, and they stay for a very short space of time. And both places are not looking at the whole story of the individual. To take a whole story of the trauma takes time, and it takes trust. And both of those things are, not happening in short times in an emergency department and in an inpatient unit. But then the problem is, by the time the person goes into community care, then she's often the stories again not passed forward or not taken, and so it becomes this piecemeal care that happens. I completely agree that we're missing the big picture. I have a particular hatred of the term borderline personality disorder because I think that this is a whole can of worms here. But it's a diagnosis that doesn't take often the horrible traumas into account for the women who have that diagnosis and really then are on the wrong tram in terms of treatment, because they really do need a lot of trauma therapy. But it's where is that going to be delivered? Who's taking the full story so that the clinicians are fully aware that here is a woman who, may have a horrible story of incest in her early life, which is reverberating through the presentations that she has subsequently. So therefore, if she's put into seclusion or there's any behaviour that is invalidating of her, that will heighten the trauma. So, I think we could do some things now. We can educate our clinical workforce to actually be able to take the stories in a sensitive way that doesn't re-traumatise people. But as Brinda says, that's very hard in the situation of somebody who's a patient against her will or who receives medication against her will. But nonetheless, I think we can do better than we're doing at the moment.
Okay, great. Thank you. Now, I have another question. This one is for Juliet and Charlotte. Service providers often engage with family members around care plans for consumers of mental health services. As a result, there are times when service providers have engaged perpetrators of domestic and family violence without recognising the abuse. What can services do to address this? Juliet,
I'll go first. That's a great question. And this was something that did come up in our research that I didn't have time to talk to today. But we certainly spoke to women who said that, that they were in the unit and staff there were consulting with family members or partners, ex-partners, where there had been domestic and family violence for histories, to get an idea of what was happening for the consumer. And, I mean, clearly this was unacceptable. There were some things which actually link in with what was just being said around the previous question, and that is the passing on of information in a timely manner. And it could be where an intake is being done in one particular area, the information isn't gathered or it's assumed to still be the same. And so staff on intake are not actually checking in to make sure that, say, next of kin is the right person or if that has changed at all. Now, what we found very interesting when we took this to the workshops was there were a range of responses from the service providers. Now, most of the service providers said, look, this was unacceptable. We shouldn't be speaking to family members where there's a history of violence there or where it's been identified. But there was a significant minority that did say, well, we still need to get a history. We still need to get information. So if that's where we get it from, then we need to speak to the ex-partner, for example. Now, I mean, that's extremely disturbing to hear. And given that, we're in, 4 years since the Royal Commission into Family Violence in Victoria, we should be doing better than that now. So we do address this in our guidelines, one that I wasn't able to get to, but it's something that does need to be taken very seriously, and in no circumstances would we recommend speaking to someone where there's a history of violence there for information about a consumer.
Okay, thank you. Charlotte?
Yeah, I think I've got 2 points on this. To reiterate one of the previous points, I think this is where advance statements could actually play a role, and a really important role, in denoting somebody's history and stopping them having to repeat traumatic information time and again, and ensure it's passed from service to service and step through. The statement follows you, so if that statement contained this information, it would enable services to be informed in a single document. I appreciate these will be complex documents to structure, but I think it is more than possible to do that. And certainly at the Mental Health Legal Centre, we have prepared advance statements of that nature for clients so that clinicians are aware when somebody walks in or is admitted to hospital of the trauma they've been through in the past and can understand why they may become very, very distressed. I think the other thing to consider in the issue of violence being perpetrated against consumers of mental health services, and then those people being relied upon in the system, is that the courts find this incredibly complex. It comes up a lot in family law. As you can imagine, the issue of a mental illness is often used, particularly against women, as an expression that they're not capable of raising children. And these types of coercive behaviours are being played out across legal and medical systems. So for myself, one of the biggest concerns is that these coercive behaviours are empowered through the medical system in lots of ways, through validating what people are told, when the person with the mental illness is often not embraced and not encouraged to speak to what's been actually happening to them. And again, when clients of ours have spoken up and said that they have been victims of violence and abuse, they've been told it's part of their psychosis and part of their illness, that they believe these things. So again, there is so many layers of this complexity to what's going on, that I think the only way to actually move those things forward and to say these are the people that I trust and these are the people that I don't, is to ensure that people are using what systems we do have now, and then to look forward to the Royal Commission to say, what can we do and how can we be so much better than we are? And I do believe that peer support and peer-led workers can change those outcomes dramatically.
Okay, thank you. Thank you very much for those comments. Jayashri and Brenda, did you want to respond to that question as well?
It's Jayashri here. It is a very tricky question and vexed in lots and lots of different ways. And it does come down, I think, to the trying to bridge the fragmentation of information in a way that, it just stays there for the next time and so on, and people have access that they need to a good complex history. But that means that the clinicians need to have the time and place to be able to actually take a good history, to be able to actually develop a bond, to develop a rapport with the individual, so that they can do this. And that's often another whole step. I mean, it comes back to the architecture of wards. It comes back to the involuntary nature of some of the admissions and things, which immediately doesn't lend itself to making a good bond with somebody. So we've got this very paradoxical system that has inherent flaws in helping clinicians, and many times the clinicians will tell you this. They're really trying to do their best, but they're not adequately resourced in either the training to be able to think about trauma and work out that can happen in a private setting with a private consultant psychiatrist or registrar or whatever, or therapist, but not so much in the public system because of the pressure and the rapid movements. So we've got all kinds of issues, and I really think it'd be really good to redesign the whole thing with the consumers driving a lot of the redesign. And this isn't a system that's working at the present to really meet anyone's needs, particularly. And this issue of confidentiality and privacy and safety in the woman who is the subject of awful violence at home is a whole issue that we've got to get better at doing.
Thank you. Now, Brenda, can I throw the last question to you, and please do respond to that previous question if you wish as well. But I have a new question for you in particular. How can the role of lived experienced workers be further integrated and empowered in supporting women who experience violence and fear violence within inpatient mental health units?
I do want to respond to the issue of carers and support in families, and they're being used as a principal place of information for consumers, particularly when a consumer has expressed that they're actually the perpetrators of violence. I think this is appalling. I think it's appalling that staff think that it's okay to keep getting that information, and even if they think that they can temper it with the information from the consumer. It goes to that sort of thing of, I'm not paranoid if people are picking on me. If people are being violent, then someone's going to react in a trauma responsive way, and that is really problematic. That might be a bit confusing to people, but that it's really, really problematic to me, and it's problematic to a lot of consumers that carers of family members are believed over consumers. Again, it's this thing of you're only saying that because you're unwell. It's a manifestation of your paranoia or your delusion. And your mum look at her, or your dad look at him. He's a perfectly nice gentleman, and he wouldn't be doing these things. So I think this is a really significant problem, and I think that staff need to get it in their head that if a consumer says that someone's being violent to them, then they have to believe that in absolutely the first instance, because the consumer wouldn't be saying it if there wasn't something in that truth. To lived experience, so to move to the issue of lived experience workers, in particular peer support workers, and I'm only talking about consumer peer support workers. I don't think that carer peer support workers have a role in this space. I think that we should be looking at peer-delivered services. It was great that the Commission came down with a recommendation to set up a peer-delivered bed-based service, but one service isn't going to do it for this issue, let alone all of the other issues that consumers have in services. So I think that we need to be looking much more at peer-delivered services. I also think it would be really good for services like CASA. It's a great service. They don't use peer support workers. And I think that the evidence, the little project that was done at VIMIAC last year called Phoenix, that used peer support services to work with people that had experienced sexual violence in inpatient units, it was a very small project, only had about 7 consumers actually use it, but that's principally because it was such a short project. It was only 12 months. That showed really good evidence that peer support workers have a lot to offer in this space, and I would really like to explore whether specialist services like CASA could also employ peer support workers to support consumers in that space, and not just therapists and social workers, but actually look at peer support workers.
Okay, thank you. And finishing with another strong connection. Now, unfortunately, our time is up. So if I could thank all of our panel members, thank you so much for your contributions. For those who are listening on the ANROWS website, there's a bio of all of the presenters. Please have a look at their backgrounds if you are interested. This is the webinar recording will be available on the ANROWS website. So if you'd like to view it again or others, pass it on to others. The research report, Preventing Gender-Based Violence in Mental Health Inpatient Units, is also available on the ANROWS site. And of course, if you are interested in more information about upcoming webinars and ANROWS events, please have a look at everything available on that site. Thank you so much to ANROWS for hosting this presentation, and thank you to all of you again. And now it's time for us to sign out. Thanks.